Okay, good afternoon. Sounds like you can hear me. My name is Bill O'Brien. I'm the Senior Advisor for Program Innovation at the National Endowment for the Arts. We're delighted to be here. We've got a lot of ground to cover, so I'm going to dive right in. Before we start, I do have one quick announcement having to do with the videotape. This event is being video recorded. The recording will be available for viewing at www.arts.gov after the conference. By attending this event, your voice and likeness may appear on the archived video shown at arts.gov. So just so you know. So as I said, I'm from the National Endowment for the Arts, and my colleague Sunil Iyengar will be presenting the second half of this theme that we're on, which, as you can see, is bringing intellectual clarity to emotional chaos. We're really excited to be here, especially sharing an investigation on those themes with you all, because we really do believe that this is an area of shared discovery, artistic discovery, and psychological discovery is something that has a lot in common. And we're going to look at some things that we've been doing through a partnership with the Department of Defense, and then we're going to share a little bit of some of the advanced work that's going on in research with music therapy and how they're incorporating some neuroscience into some of the newest work there. So just a little bit of an origin story on how this theme of intellectual clarity from emotional chaos came about. So this is the cover of a book called Operation Homecoming. This was a project that was supported by the National Endowment beginning in 2004. And it really sort of grew out of a natural activity for the endowment, which is to create a piece of art, an artwork, in this case a book. The purpose of this book in 2004 was to provide the general public with an opportunity to connect through this shared artwork with the military experience. 2004 was a decade ago, and we were still fairly new in these wars. We were still, I think, coming to grips with the fact that we had people out there fighting them, and this was just an ability for us to create a platform for some shared stories from the military community. But one of the things that happened throughout the course of these workshops, basically, we brought in some very famous, accomplished writers who would go into military settings. They could be hospitals, they could be military bases, aircraft carriers. They went on to bases in Iraq and Afghanistan, and basically just provided an opportunity for people to sit down, pick up a pen, put down their stories. They could be anything. Some of them were funny, some of them were somewhat trauma-based. But that wasn't really the focus of the book. The book was really just there for people to tell their stories, whatever stories they felt needed to be told. But one of the things that we kept hearing as that project rolled, along for about 4 years before the book came out, was that these military folks, whether or not they submitted a piece for the book or wanted to be in the book, they still said that taking that minute to think about their lives and their lives within the context of the military experience was a very useful thing for them to do, just to for their own context and their own sort of sense of self, because there's so much, as you can imagine, personal transition that happens when you go into service, especially when you go into service in a time of war, and then in the all the issues that you face in reintegration at the conclusion of your service. Brings up an awful lot of self-identity issues that arts-based activity can help sort through. So then in, I guess, 2010, we had published the book. We were very conscious of the fact that, this war has drug on for 10 years by that point. And we wanted to reassess how we could partner with the military in a meaningful a meaningful way that we could contribute whatever we could. And we became aware, a long story we don't have time to get into, but there's a facility at the Walter Reed National Military Medical Center called the National Intrepid Center of Excellence, or NICO. And the NICO is a very interesting place. It's very centered and focused on providing integrative care. And integrative care is a term that I had heard, but I'd never seen it really addressed in such an authentic and such a passionate way as the folks up at NICO were designing. And it really is at the source of the NICO design and the NICO philosophy is this notion of integrative care. So this is what that wheel looked like when we started our conversations with them. As you can see, there are different types of interventionists around a wheel of care. Some of it a little bit more focused on traditional Western medicine types of things, but there's also more complementary and alternative medicines that were being embraced, like acupuncture and yoga and arts therapies. And what really impressed us and what really, got us thinking about what we might contribute to this is the notion that what they were discovering in each of these separate interventions was very purposefully going to be shared across the modalities that were being incorporated. So there was really a high level of commitment in sharing across these platforms information that would help both the patient understand what his healing journey was about, and also so that discovery in one place could be shared and could benefit efforts happening somewhere else. So as the Healing Arts program continued to expand, it's gotten to a point now where it includes group art therapy sessions, individual art therapy sessions, family art therapy sessions. Families are a very big part of this. Spouses get involved in some of these activities. We have expressive writing clinical sessions that we based a little bit on work that has emanated out of your field. I'll talk more about that in just a minute. We have creative writing workshops that are not in the clinical setting, but are more of arts engagement opportunities, but are somehow affiliated and help expand some of what's going on in the clinical setting into a more informal setting. And then music therapy that we've also now expanded to include. I did want to mention that the executive director of the American Music Therapy Association, who helped find one of our panelists, is here today, Andrea Farbman. She's right here. And there's a lot of exciting things happening with music therapy, and so I'm delighted to have her here in the room with you as we investigate all of this. So this is a quote some of you may be familiar with, William Osler. When I ran into it, it really helped me understand what we were trying to do in tandem with these other partners in these efforts. William Osler, as you probably know, is often credited as being the father of modern medicine and patient-centered care. And I really do like this quote. Listen to your patient, he's telling you the diagnosis. And as we started to try to understand what the writing activities could bring into this setting, as I mentioned, we started looking into lit reviews in anything that we could find that could help inform in a scientific way how we might advance our understanding of what's happening. And so Jamie Pennebaker, as many of you probably know, is a pioneer in expressive writing. And there's others like Denise Sloan and others who've been advancing that work over the last 20 years or so. And it was very intriguing and interesting for us who were looking at these things from an artistic investigation, to then look at it from a psychologist's viewpoint, and to see the kinds of experiments that they were doing and what kind of boundary conditions that they were defining, and that they were looking at this naturally from sort of a exposure therapy perspective, and looking at it as a way of habituating with trauma, for example. And certainly we walked in knowing that there was some good solid work that we could look back to, but we also wanted to think about how do we bring the artistic perspective into this, and how can that expand the context of what it is that we were looking at. And that's where, in our lit review, we went back even farther than Jamie Pennebaker to Aristotle, and the idea of catharsis as the outcome of catharsis being intellectual clarity from emotional chaos. When I look at arts making, arts engagement, I can see that makes absolute sense to me on so many levels, whether it's a play that is dealing with ideas that are very complicated, and they are carefully structured into a narrative that helps people convene around certain ideas, whatever those ideas are. um, all visual data that comes at you and you try to make sense of, and that can turn into a painting like Starry, Starry Night. We hear all kinds of sounds and noise that musicians turn into melody and rhythm. And I think in this case, in this setting, when a patient comes in for 4 weeks and is getting a tremendous amount of attention and care from lots of different perspectives, one of the things that we're able to provide, or what they're able to provide, is opportunities for the service member to really take a moment through an artistic making process to contextualize what are their issues, what are they trying to confront. And these patients are there for 4 weeks at the NICO in Bethesda. They come from all over the country. Generally, people who have been attempting to heal and have not had as much success as their providers would like. So they're referred to the NICO. And there's two traits that they have in common. One is that they have some form of TBI, usually in a mild form of traumatic brain injury, and that they have associated psychological health issues. PTS is certainly one of the more pronounced one of those, but I think you can look at all of this as being that, what we've termed as being the invisible wounds and the signature wounds of these last 2 wars. So here, I'm just going to very quickly go through some of the themes that have come up in the mask making. This is issues related to identity. This is some mask works that have explored how they view their own injuries. This one comes up quite a bit in terms of split sense of self. And then we also, as I said, we get caregivers, very often wives, sometimes some of the healthcare providers, but they come up with obviously some very different takes on what it is that they're there to do. Where I think some of this gets to be very interesting for all of us as we've been observing this is that, yes, there is a lot of trauma that's often processed, and you've seen that in the mask, but there's also very often a much more proactive and positive thing that they're really trying to sort through and crystallize. Here you can see someone who's putting into a visual form the notion of grasping for normal. This is someone who's really describing here the sense that is becoming clear to them in this 4-week journey where color is coming out of the darkness. So very quickly we do, in the writing sessions, we do some expressive writing that is in the clinical setting, and this is carried out through prompts that we've developed in consultation with psychologists who've been working with expressive writing and written expressive therapy, as well as from the feedback we've gotten from the patients over the last couple of years. And then we do creative writing sessions where we bring in some very gifted writers who are also combat veterans so that they can help these patients understand how they might be able to pick up the pen and how they can prompt them into becoming active, which has been really to a surprising extent embraced by the patient population. So one of the patients that came through, and I think his reading of a poem called Seeing Isn't Believing is worth about 10,000 of my words, so I'll let him do the next little bit of speaking for us. This is a short poem, and it was written in the creative writing session.
My title is called Seeing Isn't Believing. So I daydream, what if I were an amputee, and this is what I see. The teacher asked, who threw that? It wasn't me. Not having to worry about the dryer ate my other sock. Damn! Where's my other sock? You're too tall for this ride. Well, for a couple of minutes, I'll kiss these legs goodbye. So I talk with my buddy, which by the way, is an amputee. And he says, yeah, when I go home, people open and hold the door. Even the most rudest people. Everybody asks, can I carry your bags? But for me, it's, what's wrong with you? Ain't nothing wrong with your legs or your back. You got hands, so pick that up and carry that. The door's swinging shut, too fast for me to get there on time. You can open that. I talk with my buddy and he says, you really don't wish you was me. I wake up every day. When I look in the mirror, I notice what's missing on me. I say, well, when I look in the mirror, I notice it's not me. I can't even see me. He says, what do you mean? I say, take a look. What do you see? He says, all of you. And I say, yes, yes you do. But I don't see nothing.
Okay, so the reason I like that piece is if we're talking about the invisible wounds of war and the notion of having a hard time understanding what this is when you can't really see it, I think he did a beautiful job of, in a piece of artwork, communicating what that is. And if you listen to him talk about his work and what its role had to do in his healing, being able to crystallize that for himself and then being able to communicate it more effectively to his providers was a big part of what the whole team of people are doing at the NICO. So that is my session. We're going to move now to hear a little bit from Dr. Heechin Chae. The NICO, as I mentioned, is a facility that was developed to pursue healing and discovery and learning. And that was the initial NICO. There's about 9 of them that are at some stage of development now. And the first one that broke ground was in Fort Belvoir, just south of DC. And Dr. Chae is the person who is leading that program. And I think I just pulled up my agenda. There we go. He came up and observed the NICO in Bethesda and saw what was going on there and reached out and asked us if we'd be interested in partnering with them in investigating how this program could be replicated in the first satellite. So he's here to talk a little bit about that. And I'll just get your share going here.
Okay, thank you, Bill. Good afternoon. It's a pleasure to be here to talk to you about what's going on with art therapy program in Traumatic Brain Injury Center at Fort Belvoir. I'm a physiatrist by background. I came down from Boston to Fort Belvoir to start the TBI Traumatic Brain Injury Department 3 years ago. And actually, our clinical model is similar to the NICO site that Bill just described in Bethesda. The main difference, I would say, is that we have the luxury to treat someone for however long we want, because they're not actually coming to our program just for 4 weeks or 6 weeks. Actually, it's a true outpatient center. They're actually working full-time, and they actually go home after work. So the challenge actually is to have them come in, just like anybody who's working, to take time to come and get treatment. So as you can see, I was a little bit cautious when I was thinking about the possibility of adding expressive therapy, like art therapy, into our program, because that's just another extra appointments. So it's like almost juggling, okay, do you sacrifice physical therapy so that we can add art therapy and so on? But so I gotta say, I have to start off by saying that I did not really appreciate the power and the effectiveness of expressive therapy, especially art therapy, in a outpatient rehabilitation program for conditions such as traumatic brain injury and psychological health. We see 600 new unique patients a year, so it's a fairly busy place. And I thought that the best way to describe some of the lessons that we have learned so far is to describe a couple of cases, perhaps just focusing one more than others. But this is a story of a 31-year-old Army sergeant and infantry. These are the people that they're like the offensive, defensive linemen in football. They're the ones who are really going down to the trenches to fight. This is a typical story of somebody in the infantry in the combat. Multiple deployments. Each deployment, they come back with more injuries and nicks and things, resulting in pain, emotional changes, personality changes, cognitive changes. then next thing that you know that they have like list of diagnoses, including traumatic brain injury, post-traumatic stress disorder, sleep disturbance, chronic pain, and so on. And it starts to affect their daily functions because of the anger irritability. They actually begin to withdraw more from relationship and society. They become apathetic, and they really begin to suffer with pain. So when you place somebody like this, and they're supposed to go into full-time work, so this person was assigned to Old Guard. What they do is they actually do military marches, ceremonial things. So you can imagine when you have knee pain, they have to be very precise and exact. So the whole idea of being precise stresses him out. So you can imagine the first thing he'll do, I want to see my counselor, because I cannot handle this thing. But as a good soldier, they internalize everything. They're not supposed to complain. They're not supposed to whine. That's the warrior mentality. So what happens is you place this kind of person in a typical traditional medical model, especially as Bill said, we're supposed to listen because there's no, as far as brain injury concerned, there's really no one diagnostic test that you can put in and they'll give us exact diagnosis. We really rely on subjective report of the patient. So we really rely on their complaints, their talking to us. If they don't provide what they're going through, we cannot provide proper diagnosis and treatment. So as you can imagine, someone like this with warrior mentality, already having difficult time processing their emotional thoughts or feelings because of cognitive impairments, and being tired all the time, stressed out of job, their marriage falling apart, it can be quite overwhelming for somebody, a doctor like me, to say, okay, tell me what's going on, right? And it's like, there's always like pause. I thought that it was because of their neurological problem, but after being in this job for 3 years, I'm realizing that they're just simply overwhelmed. They just don't know where to start. And they're trying very hard to say, okay, this is a medical doctor, so I better talk about my headache. Where really the root of the problem might be something a lot deeper. There's something that they have not even started processing in order to tell their medical, psychological providers. So this is a typical story. It's really difficult to verbalize. So what happens is they do not progress. They do not really get to engage, and they eventually drop out. They stop coming because itself is too stressful. Think about it. These people are already stressed. Coming to appointment is stressful. You can imagine they're not going to come unless they're forced to do. And also second, even if they engage, because they cannot verbalize their feelings, it's really difficult for them to progress and heal. So what happens eventually is that we have this round of discussions like, boy, this person has not progressed in 3 weeks, has not progressed in 5 weeks. And we always think about what to do, such as, should we go and admit him to inpatient? Should we take him out of work? But what has happened through expressive art, and especially art therapy, is that we realize that these people have begun to benefit from art therapy. So this is second round of go. First time they did not progress, so this person just began to just check out, did not come back. And the command, his superior, forced him to come back to us. And we had to scramble and decide, okay, what can we do to help this person progress? And art therapy was one of the solutions. So this is one of the first projects that this sergeant did, and you probably heard from Bill about art mask making. So you can see this is the project that he did, and it basically depicts his feeling of paranoia that whenever he's in public, everyone is watching him and passing judgments of his behavior. Obviously, this is not what he's going to tell his therapist or psychologist or even to a physician. This is too complex thing for him to say aloud on his own. But this mask making helped him to come to this conclusion as he was describing this project to his art therapist. And this is another project that he made. This is actually pretty fascinating because he did this project randomly. He didn't go in with a thought, okay, this is what I'm going to draw. He just actually just did randomly, and the art therapist basically took the thought of it and just began to apply colors of paint. He was automatically drawn to using a painting knife tool in order to just see what happened to come up. At one point, he startled himself when a figure representing the first man he killed was seen through a scope emerged in the abstract shapes of his painting. And as you can see, that red figure in the middle, the round, blue circle is the scope as he interpreted it. And he drew the similarities without really intervention, drew similarities between his physiological experience at that moment when he killed the first man and whenever he gets angry currently, such as certainly having tunnel vision, and also dizziness, nausea, headache, and things like that. So when this discovery happened and bringing this to his psychologist session really opened up a lot of options and therapeutic modalities for our psychologist. And as you can imagine, he began to take off and really make a lot of gains. In fact, last month he was retired medically for post-traumatic stress disorder, and he moved to Kansas City with his family. And he's actually looking forward to life after the military. His condition has stabilized enough that he's actually looking to get a full-time job. This is another example where I'm just going to go quickly. It's a 36-year-old divorced Army major, veterinarian. Not many in the Army, by the way, but she happened to be one. And she had multiple deployments, and the source of trauma, I didn't list it here, but her problem was that she was forced to kill animals that she didn't want to kill, that was injured, in the streets and things like that. So that was very traumatic for her, but of course she doesn't talk about that when you see her. So this is a first mask project that she did, and it shows disapproval in herself for feeling happy in the moment she realized she survived. But later on, she realized that she doesn't approve of her being happy because she killed so many animals during deployments. And this is another project she's done line drawing, and basically she had a tremor, and that's why she couldn't do it. So that's why she couldn't stop doing veterinarian work. As you can see with the project, she learned that she could draw straight. So that's another fascinating thing. And guided imagery and emotional painting, which again, she discovered a lot through this, and taking to this psychologist session, she opened up a lot of doors to begin the healing process. So what we realized is through this project, and as you can see, actually I'm running out of time, so I'm just going to go really quick. I apologize. But we asked the patients, what is your experience with art therapy in our program? And obviously, they're all positives, wonderful. And really, the whole issue is about really learning to connect with the inner feelings and able to process their emotion in a way that they did not expect, and having ability to begin the healing process. And some of the areas that they felt like they addressed through art therapy, as you can see, is many lists, including motor skills, which is pretty fascinating to me. And they also, we asked the staff in our program, and they all felt like 100%, well, there are 19 clinical clinicians in our building, they all felt that art therapy was very positive influence in our treatment, and also should continue to be offered in our place. And I think the benefit of art therapy, in conclusion, these are things that really make me start to think and move toward research. I do believe that the actual treatment does activate certain parts of the brain, especially medial temporal lobe area, that perhaps is damaged through traumatic brain injury. And also, more importantly, I do believe it's a way of them learning to process their emotion so that they can really open up and make other conventional treatments, the effectiveness of that conventional treatment to really be add-on. So it has become an important part of our interdisciplinary program for traumatic brain injury and post-traumatic stress patients. Thank you very much.
Thank you. And as we just switch computers, our next speaker, first of all, thank you so much, Dr. Chae, for coming. It's always great hearing from you on your take on what's happening at Fort Belvoir and at the NICO there. Next up, we have Ed Roth, Associate Professor of Music Therapy, Coordinator of Clinical Experiences, and Co-Founder and Director of the Laboratory for Brain Research and Interdisciplinary Neurosciences, BRAIN, or BRAIN, at Western Michigan. That's a title so long that we are now way over time, and I'm going to have to cancel Sunil's panel. Just kidding. I have not had much time to talk about our music therapy program, which is integrating at the NICO in Bethesda, and it's been a terrific program, way more demand than we can address. But we're going to talk a little bit now about some of the forward work that's happening in research in music therapy. Thanks.
I just need to slide this. Hand this to the ceiling. Excuse the delay. Okay. Good enough. Okay, well, because the title of my lab is what caused us to go over time, this is going to be a sprint, so strap in. Actually, one of the priorities we had when we discussed this panel was to make sure that we left time for, plenty of time for questions. So I think what I might do is I'll skip a few slides and give the overview rather than get into the details. And so what I wanted to do is, first of all, connect my little 10-minute section to the overall title or the theme of the panel, which is this idea of creative expression. And so part of what I'll talk about today is the use of music improvisation or clinical music improvisation as a method of creative expression towards clinical outcomes. So as an arts-based therapy, where music is our primary therapeutic stimulus, for the last 70 years, really since our inception, we've been steeped in the social sciences, and we've really looked at music as a therapy from an arts-based or a cultural phenomenon. And it's really been only the last 15, maybe 20 years or so, where we've looked at music from a neurobiological model, and that is trying to understand auditory perception, so musical perception and musical production, in terms of its interaction and requirements on the central nervous system. And then how that knowledge gets translated into something that's clinically meaningful for diagnosis related to motor deficiencies, cognition, and speech and language pathology. So today I'm just going to talk about the very first step. Like Dr. Chae mentioned also, I think it's helpful sometimes to understand things from a case-based frame of reference. So I'm going to talk a little bit today about step one, which is this feasibility study that we're pursuing to try to understand the application of music improvisation for children who have experienced some type of trauma. So many of you are probably familiar with this phenomenon known as alexithymia, and it's really marked by this impairment for children to be able to identify and understand, and most importantly, to be able to actually express emotion. There are impairments in social cognition as well. It affects mostly children with trauma and those who have diagnosis along the autism spectrum disorder. I put these little because I think people can connect to these colloquialisms. Musicologists and neuroscientists who study parallels between music and language have identified several of those similarities. And many people actually think that music is a superior or at least a more robust language system specifically for the expression of emotion. So, which of course then is relevant to a population of people who can't use speech to express emotion. They can't tell you, I'm terrified. They can't tell you, I'm angry, I'm enraged with words. Where our clinical literature actually is rich in the history of these descriptions and phenomenologic studies where music therapists use clinical improvisation with great frequency, both with people who've experienced trauma and just generally people who have emotional disorders for the purpose of self-expression. So I'm moving along quickly now. So in 2008, my research partner, somebody who's become my research partner after he published a study, Charles Lim, what he found is this dissociated pattern of neural activity in jazz pianists.
while they were improvising. And I probably don't need to say it for this particular audience, but all that just simply means that one part of the brain became activated while another part of the brain was simultaneously deactivated during improvisation. And so, let me see if this will show up. Good. So the medial prefrontal cortices became activated. In part, this part of the brain is involved with autobiographical self-expression. So this idea of, I want you to know how I feel, I want you to know what I think, and I want you to know about me, became activated during improvisation. And then the dorsolateral prefrontal cortices, which in part serve an inhibitory function through the sort of self-regulation of behavior, became deactivated. And so they conceptualize this pattern of neural activity as being uninhibited self-expression, or what I've come to think of as the neural footprint of the really bad first date. And if you've had one, you know what I'm talking about. Okay, so this is another example of improvisation, but with freestyle rap. And yet I do mean like hip-hop rapping, where they had to improvise, just like the jazz pianists improvised, on top of a lyrical or a semantic structure. And they also observed activation in medial prefrontal cortex and deactivation in dorsolateral prefrontal cortex. Boy, time-wise, I'm skipping that. So this is my collaborator. This is Dr. Charles Lim. He's who I mentioned in the previous slides. He's a neurosurgeon at Johns Hopkins, if you don't know who he is. And he also happens to be, in fact, he might not like it if I introduced him this way, but he's really quite a lovely jazz musician also. And he thinks of himself as a novice, but he has chops. And he's actually part of the faculty at the Peabody Conservatory of Music. And he's seen here on stage during his TED Talk. So this is the basis of our study. I'll start with the musical material. So the musical requirements of this study were suitable for musically naive or untrained children. So the idea is, if we're going to build the basic scientific knowledge about a clinical application, we want to do it with the type of population with whom we most likely would come into contact with, which is non-musicians. And so these 5 notes that I've highlighted for you here represent something called a pentatonic scale. And the subject could play any note at any time, and it would always sound musically correct, or musically pleasing, if you prefer that language. Okay, there's no wrong notes. The subject in this study was a 12-year-old female. She had only taken piano lessons for about 6 months, and they had ended 3 years ago, which was close enough for us to consider her untrained. There are 3 conditions. Yeah, it's actually kind of dark on the screen. This is the subject in the scanner. That's her face. That's her right hand. This is the keyboard. And that's the facial guard. There are 3 conditions in this study. The scale paradigm is meaning a musical scale, which is she simply played those 5 notes repetitively up and down, and it's a very low complex motor behavior. And if this video works, you'll actually hear how this sounds. So this went on for 30 seconds while she was being scanned. And then the improvisation paradigm required the participant to use those same 5 notes in the same 1 note per pulse pattern, but allowed her to make up the order for the purpose of creative expression, so that she could actually generate unique musical ideas.
Improvise.
So you can hear she's just making it up. This is completely novel music performance, and it sounds quite nice. The interactive improvisation paradigm now required the participant to listen to 4 bars of pre-recorded improvisation. We recorded it a couple nights before. And so she would listen to the musical prompt and then respond to it in some way that she thought was reciprocal to what she had just heard, and then also add it on, like a verbal conversation, or at least a good one.
Listen, then improvise.
So there's the musical prompt, and this is her response. And another prompt, and that went back and forth for 30 seconds. Okay, this is all lovely, but I'm going to skip it. Okay, so this table, again, for the sake of time, this is demonstrating the deactivations during that first type of improvisation that I showed you, where she didn't play in response to anything. She was simply being creative over time. And I suppose to kind of get to it, and for the sake of time, not being able to get into all this data, what's most interesting about this pattern of deactivation is that it has some similarities with patterns of activation observed during flow states, or states of flow, and creative behavior. And then this table demonstrates areas of activation during the interactive improvisation. So some of the things you'll see here is left inferior frontal gyrus was activated, left insula, left Rolandic operculum. These are areas involved with communication. It's basically talking about Broca's and Wernicke's area. What's most interesting to us at this point is activation of the angular, insula, and supramarginal gyri have been implicated or connected to empathy. In one of the most robust outcomes reported in the clinical literature as a result of clinical improvisation is the development of empathic behavior in clients. So I just got my 1-minute note. So here are my last 2 slides. First, I don't know for sure, we don't know for sure, but we think this was the first pediatric subject in the world to actually be scanned while actively making music. This might seem like a small thing to you when you're listening to it, but everything worked. If you've ever been in an MRI, you know how loud it is, and to try to actually make music in a scanner is not a small thing. The musical material was sufficiently evocative, meaning it provoked a response from this subject in a very novel way. She understood what she was supposed to do. The design yielded meaningful comparisons, and we learned that we have to actually add some exclusionary criteria. We expected there to be an artifact. She was wearing braces. We didn't expect to lose the entire prefrontal cortex. So now our sample frame is children who are 9 to 12 years old. So now we have to find children who are 9 to 12 years old who don't have braces in the United States. Good luck. Thank you. I appreciate it. Okay. Yeah. So, yeah, I can feel some nervous energy. So I'll skip the first 2 bullets. Really, what's most interesting to us is this child can actually use this type of musical material to improvise, telling us that perhaps other children can as well. She could do it inside of a magnet, and the neural markers that we observed in both types of improvisation indicated that she was probably engaged in a creative experience, interesting enough. More interesting that it was likely to be communicative experience, and then most interesting to us with an N of 1 is that she may have also been involved in an empathic experience. That's the finish line. Thank you.
Great. Thank you, Ed. Okay, so we are definitely running over, and we are supposed to be making room for the next panel in about 5 minutes. We did want to open up for any questions, and maybe, Sunil, if you guys want to start with your computers before we're done with this, that's totally fine too. Okay, so we'll take about 5 minutes, 5 or 6 minutes, and just answer any questions. Because of the video, the way that we're going to need to do this is go ahead and tell me your name and what your question is. I'll repeat your question back for the audience, but also for the video. So happy to take any questions, if anybody, or any comments, any. Yes. So the question for anyone who missed it in the back, and also anyone watching in the future, is whether anyone up here feels that there's some sort of a correlation between what we're seeing and finding and feeling here with mindfulness, and that in her work that she's found there to be some correlation in the kind of the way that it integrates and some of what's being discovered in mindfulness as having some overlap. Either?
Well, from our experience, we do know that actually all the patients report that they feel less anxious.
Can you hear that in the back?
They feel more relaxed after art therapy sessions, and I think that's been pretty consistent observation for us. So from my perspective is we're trying to find a neuroanatomical or neurophysiological reason for that. Whether it be meditation, art therapy, acupuncture comes to my mind as well. All this, intervention, I do believe that it targets similar areas in the brain. Yeah, along with other specific perks for each modality. I'm sure music therapy, art therapy has some other additional effect, but I think they do target same areas in the brain. That's something that all the research is sort of headed toward. And Ed mentioned about natal temporal lobe and prefrontal cortex. That's all the similar areas that we're observing every research that we see for this type of modalities.
Yeah, I don't know if this mic is on. You can hear it or not? Yes? Okay, good. So one of the things I didn't mention is during that first type of improvisation where the subject was simply freely improvising, and actually some data I didn't show you today where she was improvising even more freely. She wasn't, she didn't have to simply play one note per pulse. Her neural representation showed markers of activation in the default mode network, which of course has been related to daydreaming and creative behavior. So I think that's connected to your idea of meditation and also.
And I would say just, I'm not the expert on this, but I do know that at the NICO that some of the crosstalk that happens in that integrative model that is particularly compelling for that team is across, especially the music therapist, our board-certified music therapist that we have working, who has been having some interesting dialogue with the acupuncturist and yoga instructor who also has some background in mindfulness. So I know that they're very interested in trying to track this on a more scientific level and looking at autonomic responses that may be able to track through heart rate variability, maybe epigenetics in the future, but there may be some ways of really tracking this in a biological way, similar to the way that you're looking at it from a neurological standpoint.
Yeah, no, I was just going to say that, we can go on and on this topic, but one thing I've said, our program pretty much tried to avoid medication because of that topic we're talking about. I think it's more powerful anxiolytic than any medications out there. So just wanted to add that point.
Great, and I think that's it. Thank you for coming, and if you like this, stay tuned for Act 2, where we're going to be looking more, we're going to be taking these same themes and then looking at a different population in terms of youth. So that'll be up in just a minute. Thanks again. And thank you, Ed, and thank you, Heechin.